Dr. Jaffe, many functional cardiologists have recommended testing lipoprotein A more routinely on patients. While I have read several articles on its physiology and complications, it seems difficult to lower with most of the available protocols. Will you please comment on its importance and suggestions when finding high levels?
Lipoprotein A is a carrier of fat. LDL contains a backbone of protein that a fellow named Bob Maley called lipoprotein. And lipoprotein A was the first one that was characterized. And it comes out of a profound mistake. The mistake is called the diet-heart hypothesis, and the mistake fundamentally says, or the hypothesis that has been disproven, shall I say, says that the fat you eat determines the fat in your bloodstream. And that's logical. And some very prominent scientists got behind that idea. Although from the very beginning, it was very clear that if you changed your lifestyle, you changed your lipoproteins. But if you fought with the lipoproteins, if you had a disease-oriented view of lipoprotein A as a risk factor and you were medically trying to modulate it, the results were erratic, uneven, inconsistent. So yes, while lipoprotein A is a marker, it is not a predictive biomarker. It does not rise to the value or predictive significance of the 8 predictive biomarkers that cover epigenetics. And why would a clinician be taught that lipoprotein A should be lower? Well, because people who have repair deficits, known as inflammation, people who have maldigestion, and as a systemic consequence have delayed allergies, all of the upregulated molecules, all of the molecules that your liver produces, and by the way, the liver produces lipoprotein, the backbone, your liver determines what your blood fats are going to be. And if you have a healthy metabolism and you can detoxify the stresses and toxins of modern high-tech living, your lipoprotein A, as a beneficial consequence, will go down without directly addressing or suppressing the LPA, the lipoprotein A. And our colleague is absolutely correct. If you go to the American Heart Association or the American College of Cardiology, some of their support comes from the laboratories and companies that make LPA protocols. If part of the question is, do I know a protocol that effectively lowers lipoprotein A and is safe? The answer is no, I don't. But I'm trying to be clear that lipoprotein A is just a derivative downstream marker, and it will respond to what we eat and drink, what we think and do. And when we choose to organize ourselves around nature, nurture, and wholeness, eating the foods that we can digest, assimilate, and eliminate without immune burden, then we're more likely to get restorative sleep. Then we're more likely to repair ourselves. Then we're more likely to downregulate the inducible proteins. And lipoprotein is one of many inducible proteins. So bottom line, don't worry about it. If you measure it, just take note of it. Explain to people that people have very different levels at different times of their life. And if they choose healthier habits, one of the benefits is highly likely to be lipoprotein A will diminish because the need for it, the repair deficit, the self-attack, the inflammation and autoimmunity, will have been addressed at their cause with the self-assessments, the 4 self-assessments and the 8 predictive biomarkers. So it's current, that is, lipoprotein A is in the conversation. If you go to PubMed, there are many articles that tell you different levels of lipoprotein A, although there is not a consensus, and there certainly is only a hypothesis about protocols to reduce lipoprotein A. In fact, I'm old enough that I was taught that it didn't matter. It was the total amount of fat you ate. Then they realized it had to do with saturated fat and unsaturated fat. Then they realized it had to do with things that got into the fat because of the feed that was contaminated. And then there were other insights that over the decades have confirmed what, from my point of view, Bob Maley, Don Fry, and myself confirmed in animal models in the late 1970s at NIH. And good news, when the animals had enough of what they needed, the essential nutrients that they needed, their lipids were fine. Now, we could induce very high levels of blood fat. I mean, much higher than you would see in clinical practice. And the animals that had enough of the good stuff had no damage to their coronary arteries, to their blood vessels. And it took many years after that before folks like Jack Lewin, when he ran the American College of Cardiology, he was very actively recruiting people to give talks about health promotion rather than just focusing on assuming that an elevation is a pathology and fighting with the pathology. So Jack, at least at his level, understood why nature, nurture, and wholeness and habits of daily living can greatly reduce your risk or increase your risk, depending on which habits you choose. And the last analysis that I saw was that more than 80% of heart disease, vascular disease, stroke risk, hypertension risk, more than 80% of it is modulatable. You can change your thoughts and your habits and dramatically reduce your risk and confirm it in non-invasive ways. So that's a lot about lipoprotein A, but it is one of my favorite subjects. And it is one of many inducible proteins. It's one of many things that people talk about but rarely modulate. And you will find healthier levels in people who follow our lifestyle program.